come across any of my students handling a patient without wearing the gloves or having their masks on, I think I will love to suggest that they be discontinued from medical school. That's how serious it is. And when you look at it in another perspective, if you are not protected, your patients are not protected. If you are not safe for yourself, you are not safe for your patients. I mean, like, you handle this patient bare hands, then you handle the next patient bare hands or without having to wash your hands or sanitize, then there is a possibility probably you might transmit the infection from this patient to the next without you knowing. You are doing all that probably for the best interest of the patient, but at the end of the day, you end up doing harm, and you have probably taken an oath not to do harm. But the other thing now comes, I will also add something on waste disposal. Dr. Ellen really emphasized something on waste disposal. In the hospital, I have had instances where the nurse has emphasized over and over again, this is the bin for this waste disposal, this is the bin for this waste disposal. But people don't seem to listen to that. Because when probably the one who is collecting the waste later in the day comes to pick the waste, they have to, this is the infectious waste, so I will dispose it here. But when you have, for example, infectious waste being now disposed to non-infectious waste, when they go to dispose that waste, they will dispose it to a site probably designated for non-infectious waste. And we'll end up now having that cycle over and over again. So the issue about infection prevention, we have a responsibility as people who come into contact with the patient, or people who probably advise the patient in one way or the other. Thank you.
Thank you. There's this concept of medication non-adherence that we discussed today, right? And it was one of the main drivers of AMR. So my question to you, what are the best steps we can take to ensure that the patients fully adhere to their medication and complete the course?
Okay, let me respond to it this way. Okay, the best way to make a patient maybe finish the dose, yeah, it's to tell them the worst that can happen to them if the disease continues, or yeah, just tell them the negative impact of the infection. Yeah.
Okay, so first, we can do that by rational prescribing. So you only prescribe when necessary. Yes, and secondly, we can do that by educating the patient on the dangers of not completing the dose. Yeah, let the patient be aware that if this dose is not completed, this and this and this will happen. Yeah, so by that, they will be able to do the necessary. Thank you.
And to add on to what has already been said, it's to echo what Dr. Titus has said, creating that good patient-doctor relationship and trust in a way that when the patient, you've prescribed something to the patient is confident in what you've prescribed. So that way they're able to complete the dose, and also creating awareness and educating them on the effects of not completing the dosage and the benefits of completing the dosage. Yeah.
Thank you.
Let me add on to that. We are moving from the general prescribing of medicines to a more patient-tailored prescribing of medicine. That means that we look at the patient as one of the variables to consider when we are prescribing medicines. For example, let me give 2 examples for antiretroviral therapy. Usually they are supposed to take their medicines at a specific time over the long period of time that will be taken. So if you want the patient to take the medicines maybe once a day or twice a day, you have to ask the patient, what time is it comfortable for you to be taking these medicines? So you can't just be saying, hizi utakuwa unameza kila asubuhi. But there's some special consideration like dolutegravir, because of the side effect for insomnia. It's very much encouraged that the patient be taking the medicines in the morning because of that side effect. But for the rest, the time at which the patient is comfortable to take the medicine. Another example is anti-TBs. You know the repercussions that the patient is advised when they default on the medicines. So the patient comes maybe for the first phase or the second phase and they don't finish. We usually do what is called directly observed therapy, in that every day they have to report to the hospital, they take their medicine under observation. Then they leave and go about their business. Tomorrow again they come, take your medicines, then you go. And if worse comes to worse, you've heard that they're usually imprisoned for a period of time until amalize dawa ndio anawachiliwa, because the cost of treating a resistant TB infection and the implication, the public health implication to their environment, the people they are living with, their community, is very high to risk compared to their freedom. So we'll have to isolate them, put them under medication until they finish, then they are set free.
Okay, thank you. Do you have something to add on? Okay, now there's a notion, or there's a trend we've seen in the pharma industries where they prioritize profit over patient health. Okay, now we've seen even at the local level med reps from pharmaceutical industries. Wanakuja, they come to the physicians mostly, and they tell them, if you sell our drug or if you prescribe a drug, you get a commission from this amount. So what steps can we take as a nation, regulatory steps, that can we take to curb this behavior? Because this is one of the main drivers.
I think that's a very nice question. But one, it's now moving towards morality and ethics. And on medical ethics, everyone who goes through probably a medical course, they are taught on medical ethics. But now we are in a country where not only the healthcare workers are deviating from the medical ethics or from the general ethics, but even our population, everyone around us, no one cares about the ethics anymore. When you look at it, big pharma, it's a multi-billion dollars industry. And doctors, the thing that I have been trying to tell some of my colleagues or people that I come across is that as a doctor, or as a person probably who comes in contact with the patient, you might be having the best interest of the patient in mind, right? But on the other end, the big pharma, it's a controversial statement, but a big pharma might not be having the best interest of the patient in mind. Probably they are the ones making profit or optimizing on that profit. I would say that as a country, probably we need to go back to search ourselves. We have to emphasize more on ethics. Ethics as a society, and now we come into specifics on medical ethics. And if there are no ethics, we might discuss about it, because we not only anyway, in dispensing drugs in the drug industry, but we are lacking ethics in all other sectors. I would say that probably it's something that should be looked at from that point of view. Yes.
It's true about medical reps and being one of the drivers of AMR. What I can say is we need to majorly focus on our ethics as the medical professions. Some of the prescribers, you can see the trends when you sit at the pharmacy. When they are visited by a specific medical representatives, that afternoon, ni hiyo dawa tu. Kama ilikuwa tuseme a specific brand ABC, utaona tu every patient, mpaka unajiuliza kwani hawa patients wote walikuja with the same problem. It's ABC for everyone. Why? Because they've been incentivized. So what can we do about that? First of all, we remove incentives from the practice of medical representation. They can't come to the healthcare workers and say that if you push my medicine, I'll give you this. That is ethically wrong. So you remove that aspect of incentives. Secondly, we have to go to generic prescribing. You remove the brand from the prescription so that whichever brand that you have, the patient can use it comfortably. If you say this patient needs ibuprofen, whichever brand of ibuprofen that you have, the patient can use comfortably. Instead ya kuandika hapo the brand name, and then the patient is like, lakini daktari aliniandikia hii, it's not this. So when you remove that aspect of brand prescribing to generic, use of generic names in prescriptions. Another thing, we have to educate our patients between original products and generic products. Does it mean that if the patient is using the generic product, is it effective? Is it not effective? It's true some patients are more brand specific because some of the excipients in the medicines affect them, but the larger population can be able to use generically substituted medicines. That also brings down our cost in procurement of medicines and this issue of AMR. I forget the last thing that I wanted to say. The other thing that we can do about medical reps is for us at KTRH, it used to be that they can come at any time, walk in and speak to prescribers and pharmacists, but now we've limited it. You give it a limited time. That way, the influence that they had in that long period of interaction is minimized. So there's less influence, and also you can adhere to the standard guidelines. So if the standard guidelines say that this condition is treated with this, force now that you want to use that other medicine, una include. Yeah, that's it.
Just one day on what Doka said. I think it's the highest time now we come up with the National Prescribing Integrated System, where, for example, in UK, NHS, they have a National Integrated Prescribing System. I mean, it assists the doctor to make the prescription, whereas having, at the same time, it caps those practices. I mean, like you have a system where a patient comes in, you have probably diagnosed this and this. For example, you are saying that this patient has, let's say, pneumonia. In the system, it lists for you the treatment for pneumonia. You just click on the treatment for pneumonia, not the generic. it's the active molecule rather than the names. I mean, like, you need a penicillin to treat pneumonia, the penicillin is there. Then you prescribe the penicillin through the system. Then after prescribing the penicillin, to the pharmacist who is dispensing the drug, you have not directed them on which specific medication to give. So they have now the independence of telling whether I have to give this penicillin or the other, depending on the patient, as Doc has said. So I think as a country, we should try to work on that. Yes.
Okay, thank you. So, ideally, 18th November to 24th November every calendar year is the World Antimicrobial Awareness Week. Now, the main aim of this program or of this campaign is to ensure that to teach and to spread awareness on antimicrobial resistance and stewardship. So my question to you is, what steps can we take as students to ensure or maybe bring incentives to other or our peers to join this course?
Okay, I think when it comes to peers, a more informal approach is more profitable. They're able to, listen to what you have to say. Yeah, so for the ones who have attended this symposium, they've used that formal, approach. So whenever they go to talk about their peers, telling them about what the symposium was about, that's a more informal approach, and they're also able to reach more people in the same way. So that also adds on to the effect of the whole program. Yes.
Yes, thank you. We can do this through several ways. First of all, we can do it by just advising our friends, course-mates, and everyone outside there. Now that we have the knowledge of what is AMR, we can go back home and ensure that we educate those who are not aware about it. We can even do it using our social media platforms. You can put a post on Twitter and put their hashtag AMR. You see? Yeah, you will have great awareness there. Someone who will come across that post will have to see it. Those who are using Facebook, post it on Facebook. You post it on WhatsApp status, everywhere, so that we can spread awareness of the same. Thank you.
Okay. I guess this is the disadvantage of tackling the question last. So I'll just speak on what I do. So I generally use social media platforms. So what you do is just to highlight what is AMR, the impacts and how you can prevent them. And that, I think, will educate both the health students and healthcare workers and others who are not in health sectors. So just highlighting the general information to make them aware. Yeah.
And again, as you educate them, you tell them their role in doing the same, their role in creating AMR, their role of misuse, avoiding misuse and overuse of drugs. Yes, as you do that.
Okay, thank you. This concept of monotherapy and multiple drug therapy. So maybe you can guide us through it, its relationship with the MR.
I will let Doc start.
So the concept of monotherapy and multi-drug use, so it does depend on the specific condition that you're treating and what the treatment guidelines recommend. For example, let me use TB. TB, it is recommended that we use multiple drugs. So if you use only one drug, we risk the concept of resistance. That's clear. But in some cases, you'll find where there's adverse event, there's been an adverse drug event following use of anti-TBs. It's usually a combination of 4 antibacterial agents, but usually the culprit is usually isoniazid that leads to maybe liver failure or kidney failure. So when the patient has presented to the hospital with the adverse drug event, it's recommended that first of all, you withdraw all medicines and allow the patient to recover. Once the patient has recovered, you introduce these agents. It's still multiple therapy, but you introduce a single agent as you monitor the outcome for the patient. So recommended that you start with the least agent that is likely to cause an event. So when you start with the least one, usually it's the M. So you introduce, you monitor the outcome. If the outcome is good, you introduce the second one, you monitor the outcome. You introduce the third one, monitor the outcome. Introduce the fourth one, monitor the outcome. And you check where you need to do dose adjustment. Let's say it's the isoniazid that is causing the problem. Either you bring down the dose or you increase the dose, depending now on the patient need. Yeah. And also there's some diseases that only require one antimicrobial agent. But now, due to the overzealousness of the prescriber, he wants to do so many antibiotics, like 5 or so, and you're like, just one will be enough to cover everything. So in that way, when we can rationalize how we use our antibiotic and prevent or minimize AMR.
Yes, to end on what Dr. said on the issue of monotherapy and multiple drug therapy. Yes, clearly, and there are some conditions that require multiple drugs. That is known probably to everyone, right? But now the issue comes in, the issue, that's for sure, that's known. But now the issue comes in the incident where I overheard this joke somewhere, an incident where a person doesn't know what they are treating. A patient comes in the hospital, probably you are suspecting they may be having an infection. And you know clearly this infection can either be bacterial, viral, fungal, or probably a parasitic infection or any other infection. So, because probably you are not well trained, I don't know, probably because you are not well trained and you fear missing any of that, what do you decide to do? Let me give something for the viral. Let me give something. And nowadays there are such drug combinations, by the way. So you just want to get away with that by giving multiple drugs. But no, that now brings us to a very, very nasty situation of now AMR. You have been giving out these drugs treating things that are not there, but now when we need to treat things that are there, we can't treat them anymore. So I think the concept of monotherapy and multiple drugs and drug therapy should be well emphasized that when a patient is in the ward, why can't you just try to do culture and sensitivity? We have been advocating for blood cultures for every patient who is in the ward. Just try to do those cultures. Find out what's happening to this patient. Is this patient having E. coli? This is a drug for E. coli. Rather than throwing around, let me give ceftriaxone, then add a macrolide. After a macrolide, let me add a fluoroquinolone. Probably one of them will work. One of them may work, but at what expense?
Okay, thank you. Ladies and gentlemen, I'd like to thank you for having this session with us. I believe all the questions I had have been answered. If you had any question, I remember asking you to note it down. So at this point, I'd like to thank the panel members for spending your time having this fruitful discussion with us. We thank you for the knowledge that you've disseminated today. And we hope that as we continue discussing matters AMR, you shall also be invited at any point. Maybe if the audience members doesn't have a chance to ask a question right now, maybe you might be open to having a discussion with them at a later point. So I'd like to take back the program to our MC. Maybe he can guide us how we're going to do the Q&A session.
Thank you. Okay, thank you, the panelists. Before we do the Q&A question, we have our coordinator, that is Dr. Tanui, who is joining us virtually, and is to give the closing remarks. And after the closing remarks, we will give out the awards. Then is when we'll do the Q&A question as we take our refreshments. Sawa sawa. Yes, so properly. As for you can just resume.
Hi, Doc. I don't know if you can be able to hear us. Thank you. I wish to introduce Dr. Emmanuel Tanui, who's the head of AMR coordination. We call him the National AMR Focal Person from the National Public Health Institute of Kenya. And Dr. Tanui has been in the field of AMR for a while. And we do have other national coordination from the other ministries, as I mentioned. But at this juncture, I would like to invite Dr. Tanui to give some remarks as a way of integrating the national coordinating mechanism. Welcome, Dr. Tanui. Probably you can open your mic. Yes, we can hear you.
Yeah. So as you've heard, my name is Dr. Emmanuel.
Thank you so much, Dr. Tanui, for your kind remarks. We thank you equally for taking your time. We know today is on Sunday, and you have other commitments, especially the religious commitment, and we appreciate for taking time and joining us today. Thank you very much, and we appreciate the great work the NASIC is doing in supporting the county antimicrobial interagency committees. Thank you very much. This juncture, I'll go back to the MC.
Okay. At this point, we want to give small rewards token to our facilitators. So I will be reading your name, then you will come forward, and together with PHO Ndege, we will hand over it to you. So let me see who will start with. Yes, the moderator, Sam Omolo. You will be the first one. You will come and take it, and we will also have a photo session as you receive the gift. Yeah, you can clap for him as he comes. Yes, clap for him. Yeah, the next we have not really. Jeff Jagero, one of the coordinators of this event. Yes, clap for him. Yes, thank you, Obama Paul, our musician. He comes. Yeah, Sandra. Then Origi Regan. Then Brian Ochieng. Yes. Yes. Then special recognition for our poison guy. Yes, Sharif. Yeah. Msijali, nyinyi wote mtapata certificate, sawa? Mtapata certificates, then kuna refreshments after hii. Yes. Then I don't know how I will receive mine. So thank you. We'll move to Dr. Titus Gashikira. Clap for Dr. as he comes. Clap for Daktari, bana. Clap for Daktari. Thank you. And finally, Dr. Elena Chieng. Clap for Daktari as he comes. Clap for Daktari. Don't be afraid. DJ bana, ungetuwekea kakitu, ungetudropia kakitu bana, hii inakaa serious sana. Ida weka rembo. You are supposed to, yeah, you are supposed to give the closing remarks. Just give them, then we'll take the question and answer as they take their refreshments.
Thank you. My name is Ndege Ngere. Again, I wish to introduce myself. My name is Ndege Ngere. I work with the organization here, AMR Now. We are a youth-led organization working towards combating AMR. Some of the work that we're doing, we are a member of the WHO CSO Task Force on Antimicrobial Resistance, which is a global consortium of human health organization working on AMR. We're also a member of the quadripartite multi-stakeholder platform, which is a One Health organization, CSOs that are working on combating AMR. The multi-stakeholder platform is hosted by the Food and Agriculture Organization, FAO. And we are also a member of the Reno Farm Initiative, which is an initiative of the FAO. And we're also a member of the Africa Youth AMR Alliance Task Force. And last year, we were part of the team that were drafting the Africa AMR Youth Position Statement to the UN General Assembly, which was done last year. We usually do several awareness activities, and this year we were privileged to get a grant from the Trinity Challenge. And this banner here, the BioShield, is a project that we are coordinating as 3 countries, Kenya, Uganda, and Nigeria, where we have been able to build capacity on biosecurity for farms, that is for animal health, for youths across Africa. And currently we are doing field engagements that we intend to visit farms, talk to them about biosecurity and why it's important pertaining to antimicrobial resistance. We are so glad that we've been able to host this year's symposium through the support of partner organizations, specifically React Africa, were able to support us with the refreshments and the gifts that you've been able to see here. We've also have the Phoenix CBO. We also have the CASIC. We are so happy to have Dr. Helen here. I know today is on a Sunday. She was able to commit to be here today. Yesterday we also had cycling where we went towards Marani, and we came back with some youths from here around. We were able to spread some words about AMR. And this has been an annual activity. This is the 3rd year that we are doing the cycling. And next year, we plan to do more, and we will start the engagement early. I understand we talked with Jagero, and he said that we were not able to get funding from the institution since we had some delays. But next year, hopefully, we're going to do a mega symposium. And next year, early next year, we plan to have AMR Youth Summit together with other institutions like Uzima University, Masinde Muliro University, and other university in the Lake region. So we invite the youths here, the students here. If you are very interested, we would like to be part of that organization. We will be glad to have you so that we can have the Lake Region AMR Youth Summit. Otherwise, from my end, I wish to thank our facilitators, our experts who are here. We are so happy that you are really an advocate of AMR. We're going to give each and every one of you certificates through your leaders, and you're going to get them probably after 2 weeks or a week. I wish to recognize our media team, the Lance Media, for their generous support. They've been able to cover the event. The event was live If you wish to refer to some of the things that were discussed here, you can visit our website or our channel, AMR Now channel, which the Lance Media team have been able to give the feed to. We are so happy to have the partnership to have a successful event like this. Thank you very much. I give back to the MC.
Yeah, thank you. Give PHO Ndege some serious claps. Huh? Ile ya factorial inafanywa aje? Obama, ulifanya ile factorial aje? Hiyo. Unajua kufanya factorial hiyo inakaa ya nyayo. Aya, nani anajua kufanya factorial? Origi, it seems unajua kufanya factorial. Hebu tusaidie. Iya. Hebu jaribu. Ama mimi pia hata ni kama sijui. Yes. Hiyo. Thank you. Unataka kuweka hiyo wimbo? Tusakate kidogo. I don't know if the Keisusa president is still around. Tusalimie. But kama hayuko, allow me just to say a word or two for on behalf of the institution. So first of all, I want to thank all our partners for making this event a success. I want to thank all of you for coming. It would have not been an event if you were not there. I want to thank all our departments, all our association heads. I want to thank the dean of our school. He is aware of this event. And also the office of the dean of students is aware of this event. I want to thank them, the whole department that gave us access to this room. We also send our appreciation. Now, at this juncture, I will... Muko na maswali kweli? Ama mnaweza tuma tuziangalie baadaye. Nilete soda kwanza. Sawa. Now, the refreshments are going to be served. You just have to relax. We are doing it right away. And that being said, we will be having several events. Nimepata a platform. We will be having a vaccination for our students. Allow me share the schedule. This is a good platform to do the same. Tumemaliza, ndio maana nasema hizi vitu. So the vaccination schedule, pharmacy year 4 and 3 will receive their hepatitis vaccine tomorrow. Clinical medicine year 3 also. And MBCHB year 4 will receive their second booster dose tomorrow. On the Tuesday 25th, medical lab year 2 and year 1 will receive their hepatitis vaccine. Then public health year 2 and clinical medicine diploma year 2. Yes, those ones are the ones that are to receive. Others will receive as we continue. Sawa. There are a lot that has happened. We usually organize some webinars. Recently we organized a webinar for Community Health Student Association on mental health. Please, if we do such things, let us all join so that we can make our school greater again. We are having a research training that will commence soon enough. Owino, you wanted to say something? Please be brief. And Jagero, where's Jagero? Yes, Tuma coordinate with Jagero and Ndege how the refreshments are being distributed. So, Ken, please be brief.